All right, so this is the session entitled Future Perspective on Ongoing Trials from Asan Medical Center. I am Gary Mintz. My co-moderator is Jang. Our first presentation on OCTIVUS Trial is by Dr. Kang.
Thank you, Chairman. I will introduce our ongoing trial, the OCTIVUS Trial. We have two major intracoronary imaging devices for PCI guidance. One is OCT, another is IVUS. And the recent guideline recommends IVUS for left main or complex coronary artery stenting as a 2A recommendation. OCT as a reasonable alternative, except in ostial left main disease, as a same 2A indication. And in patients with a stent failure, IVUS or OCT is samely recommended as a 2A. There was three RCTs that head-to-head comparison of the OCT versus IVUS. First is the Illumian 3 optimized PCI trial that compared OCT, IVUS, angiography-guided PCI in about 450 patients, and primary endpoint was final post-PCI minimal stent area by OCT and met non-inferiority of the OCT compared to IVUS. Second is the opinion trial by the Takashi Kubo and Takashi Akasaka. And the opinion trial randomized 800 patients by OCT versus IVUS guided PCI, and 8 months follow-up angiography done, and 12 months clinical follow-up was the primary endpoint. The primary endpoint of the target vessel failure was non-inferior of the OCT compared to IVUS, and you can see the curve looks similar. And another small trials was done in Japan, and Mystic 1 trial randomized 109 patients to OCT versus IVUS guided PCI, and similar design with the 8 months follow-up angiography and 36 months clinical follow-up. Primary endpoint in segment MLA by OCT was non-inferior. However, although there was the randomized control trial, there were some limitations of prior RCTs. First is relatively small number of participants, 158 in Illumian 3 and 400 opinion, 54 Mystic 3 in OCT group, and underpowered for hard clinical outcome. And most importantly, complex lesions were excluded. Left main or triple vessel disease, ostial lesion, CTO, in-stent restenosis, bypass graft were excluded in previous randomized control trials. And follow-up angiography was performed in opinion and Mystic 3 and a little bit different from our routine clinical practice. So OCT versus IVUS guidance for PCI in all comma including complex PCI, and which would be better. So we conducted an OCTIVUS trial, OCT versus IVUS guided percutaneous coronary intervention. Trial chair is the S.J. Park, and we randomized 2,000 patients by 1,000 and 1,000. And primary endpoint was target vessel failure that was defined as composite of cardiac death, target vessel MI, and ischemia-driven TVR at 1 year. And study hypothesis was the OCT-guided PCI is non-inferior to IVUS-guided PCI with respect to target vessel failure at 1 year. This is investigator-initiated prospective multi-center pragmatic randomized trial conducted at 9 sites in South Korea since April 2018. The inclusion criteria is simple. The subject with obstructive CAD undergoing PCI with imaging guidance. Exclusion criteria is ST elevation MI, severe renal dysfunction without renal replacement therapy, and cardiogenic shock or decompensated heart failure with severe LV dysfunction, and short life expectancy. And the patient was randomized as a 1-to-1 ratio to OCT or IVUS guided PCI with the interactive well response system. And PCI procedure the protocol was very pragmatic, so we did not instructed the operators in detail. But OCT or IVUS can be used before, during, and immediately after PCI as operator wants. And PCI was guided by real-time online evaluation, and PCI procedure is performed using standard technique without any restriction. And the practical recommendation for PCI optimization was recommended with a if the distal lumen reference-based and upsizing, and EEM reference-based sizing and downsizing strategy is recommended. And avoidance of landing zone in the plaque burden more than 50% or a particularly lipid-rich plaque is recommended. And co-registration of angiography and OCTIVUS for determining stent length and precise stent replacement was recommended. A relative stent expansion of 80% MSA divided with average reference lumen area as an EA-PCI guideline recommendation was accepted. And some patient, if the relative stent, the reference lumen area is not available, and 5.5 for IVUS and 4.5 OCT criteria would be used. And primary endpoint would be target vessel failure at 1 year. And periprocedural MI, we follow the SKY definition. However, the MI event, especially for the periprocedural MI, will be also evaluated with the fourth universal definition MI and ARC2 definition. Clinical endpoints are educated in independent event education committee, and we are also planning the extended long-term follow-up at 3 and 5 years. The sample size was calculated on the non-inferiority hypothesis base. We assumed the incidence of the target vessel failure would be 8.0% in IVUS-guided PCI group, and non-inferiority margin of 3.1% was chosen to achieve the 80% of the power with the one-side Taiwan error of 0.05. The statistical analysis will be done in intention to treat population, and sensitivity analysis will be also performed on a per protocol or age-treated basis. And subgroup analysis of the primary and secondary endpoints will be performed per age, sex, ACS presentation, diabetes, renal function, LV ejection fraction, and high-risk lesion characteristics like left main, bifurcation, or multivessel disease. The trial is funded by the Cardiovascular Research Foundation and Abbott Vascular and Medtronic. However, other than financial sponsorship, the company had no role in protocol development or the implementation, management, data collection, or analysis. Now, a total of 2,008 patients were randomized for 6 years, and about 99% of enrolled patients completed 1 year clinical follow-up. In conclusion, the OCTIVUS trial is an investigator-initiated, multi-center, open-label pragmatic RCT to compare the efficacy and safety of OCT versus IVUS-guided PCI in patients receiving PCI in daily clinical practice. The primary result will be available this year. The OCTIVUS will provide compelling evidence regarding the comparative efficacy of OCT and IVUS in optimizing PCI in terms of relevant clinical endpoints. Thank you for your attention.
Okay, next will be presented by Dr. S.J. Park, PREVENT Trial.
Excuse me. Functionally insignificant lesions as higher than 0.8 FFR is default is safe as we have some data. Negative FFR death NMR per year less than 1%. This is our registry data. 0.21% region per year, but it's safe and good. So negative FFR actually means just excellent prognosis, even in the presence of angiographically proven coronary artery disease. All about the bulletproof plaque definition, pathology-wise, CABG, rupture erosions, biopsy image supported that one. All right, I just, for the interesting things, I searched for the chat, GT before, look at this, very much, clear clinical concept. Bulletproof plaque, also known as high-risk unstable plaque, which is a high likelihood of rupturing, causing thrombus events such as a heart attack, stroke. Advanced imaging techniques such as IVUS or OCT are also being used to better visualize and assess the plaque vulnerability concern. So what is the bulletproof plaque exactly? Thin fibrous cap and large lipid core and inflammation concern, the presence of inflammatory inflammatory cells such as macrophage, T cell, and neovascularization to blood-level plaque often have increased blood flow, vessel formation within them. So functionally insignificant blood-level plaque issue is to treat or not treat concern. Imaging defined blood-level plaque, just only study, prospective study. 700 acute chronic syndrome clearly demonstrate culprit, non-culprit base rate is quite similar. In a certain condition, plaque burden more than 70%, minimum lumen area less than 4, presence of a CABG fibroma, it will be higher frequency of base rate. And so prospect study clearly demonstrate blood-level plaque by VHI is concerned. And repeat core burden index, if you look at this one, so ST elevation MI, a clearly higher proportion of a repeat core burden. So some study, LCPI actually is more than 315 higher rate of MACE and included the imaging definition of blood-level plaque. Plaque burden more than 70% and CABG fibroma by OCTIVUS, minimal lumen area smaller than 4, repeat rich plaque by years of study. So it's the typical examples, negative FFR, biopsy, plaque ruptures, minimal lumen area is 3.4, plaque burden more than 70%, by years in LCPI index 400, CABG fibroma, and necrotic core more than 25%. Another case is negative FFR, CABG, ruptured thrombus here, and the higher LCPI index. Those cases all blood-level plaque. How would you treat them? This is very descriptive, Current strategy for management blood-level plaque, including lifestyle modifications, medications, statin, antiplatelet therapy, and invasive procedures, angioplasty, stenting, or bypass surgery if necessary. So, question one: optimal medical treatment for the blood-level plaque, is it really good? We have some studies, stable trials, randomized large statin dose and low statin dose clearly demonstrate decreased percent necrotic core volume. At 1 year data, we found that rosuvastatin therapy can make a plaque regression and stabilization at 1 year. So, conservative treatment, I like this sentence. Look at the lifestyle and including all the medications, stabilize the blood-level plaque and reduce the risk of rupture. These approaches should be considered and optimized before they deciding on an invasive procedure for like stenting. Really, PCI can stabilize the blood-level plaque. Stenting for blood-level plaque issues is a complex, debated topic as among the medical professionals. However, there are several factors to consider before deciding on stenting for blood-level plaque. Very interestingly, risk of, they described all the things. Risk of procedural complication, lack of reliable identification method. Even IVUS OCT clarified that one. However, it can still be challenging to accurately predict which plaques are really the highest risk of causing future event. We don't know that. Conservative treatment strategies, very useful. Incomplete understanding about the blood-level plaque progression, we have to think about that. So, stenting for blood-level plaque is still controversial issues. It's very limited data, only data, prospect, observed study, randomized. Number is relatively small. Clearly demonstrate no difference, no difference at all. However, primary endpoint minimal lumen areas in a group with BBS is clearly larger at the follow-up period. However, target lesion failure 2 years, no difference at all. Region-related MACE actually no statistically no difference. It will be higher in a conservative group. If you look at the detailed concern, pros anginas, the statistical not significant, how the number is too small, clinical driven revascularization is really higher in a group with the medical. And so final, we have some questions, patient versus medical treatment, which is better. So we prevent study. BBS와 drug-eluting stent compared the optimal medical treatment on the stenosis functionally insignificant vulnerable plaque. Everolimus Johnson stent-induced res intima hyperplasia. Maybe BBS suggests plaque stabilization and lumen enlargement. And so we randomized the region itself, apical coronary stenosis, negative FFR with the two of our following, the four conditions of image-defined vulnerable plaque, CNK fibroadenoma, minimal lumen area smaller, the plaque burden more than 70%, LCBI index more than 315. So we randomized PCI versus optimal medical treatment as a primary endpoint. Objective is whether PCI functional insignificant vulnerable plaque is a walk or not. Inclusion criteria 18 years, more than that, symptomatic, asymptomatic. The region itself is negative and vulnerable plaque, exclusion criteria like this. And primary endpoint, target vessel failure. At 2 years, composite of cardiovascular death, MI, target vessel revascularization, or unplanned hospitalization, and general educated to target vessel here, right? So these are typical examples, negative and narrowing of a proximal RAD, minimal lumen area smaller, plaque burden larger. So we deploy the VBS in the early period of our studies, high pressures, and we can get quite good, effective lumen area. So anyway, we finished and followed 2 years our data. So you want to have our answer in the next year's ACC meeting. All right. Thank you.
Thank you, SJ. So our next trial is TAILRORED-CHIP by Duk-Woo Park.
Okay, thank you. And I'm going to introduce the ongoing TAILRORED-CHIP trial. This is a pragmatic antithrombotic strategy. And the current depth guideline is simple. It's mainly based on ACS versus stable or presence or absence HBR population. Several random key trial was performed in Eastern Asian population, and many trial published in Lancet and Circulation key issue. And the East Asian paradox, this is some typical phenomenon in East Asian population. Bleeding risk much higher and the ischemic risk much lower compared to Western population. There are several plausible mechanisms for this. And the different ethnic-based tailored antithrombotic strategy was required, and some suggestion was recommended in the NICE review article. So, and the novel trend in pragmatic antithrombotic therapy is some complex escalation and de-escalation therapy. And the real world, there are many complex disease subset in the left main, CTO, bifurcation, multivessel, longer stent, and the diabetic patient. So, and also in the real world, there are many diverse scenario of high bleeding risk population, and the contemporary strategy escalation and de-escalation strategy is targeting for potency of P2I12, omission of aspirin, and duration of the depth. Many trials in performed more potent regimen was used in THEMIS PCI, COMPASS, host exam trial in targeting high ischemic risk population, and the Pegasus team is one sort of such trial. And in de-escalation therapy, like a short depth, targeting high-risk patients is global leader, and smart date, smart choice, stop that, Twilight, and TICO trial, and half of them was conducted in East Asian country, including Korea and Japan. And in targeting HBR population, master depth, senior Onyx 1, August trial was conducted, and the all-comer setting TALOS AMI and host of fire trial was conducted. And like some story about temporal antithrombotic tuning. This is a New England Journal of Review article. Bleeding and thrombosis risk is temporal dependent. Initial time, thrombosis much higher. In the later time, bleeding risk much important. So on the basis of such rationale, we designed the tailored CHIP trial, and this is the clinical trial GOB. And in initial early period, we targeting the ischemic risk, and the late period, we targeting the bleeding risk. So for early escalation, we used low dose ticagrelor plus aspirin. After 6 months, is clopidogrel only therapy, and the tailored CHIP trial targeting complex high-risk PCI patient, 2,000 patients, defined the left main, CTO, bifurcation requiring 2 stent, severe calcium, diffuse and multiple lung lesion. In clinical indication is a CKD, diabetic and severe elbow dysfunction, conventional arm, and the depth for clopidogrel plus aspirin 12 months, tailored arm. Before 6 months, we do early escalation, low dose ticagrelor plus aspirin. Later term, we just use clopidogrel alone on the basis of temporal, the ischemic and bleeding, the tendency. So, and our low dose ticagrelor was based on OPTIMA trial published in JAG, and even ticagrelor 60 milligram potency is very similar ticagrelor 90 milligram. So inclusion, I already mentioned, is complex lesion, procedural and clinical factor, and exclusion, enzyme positive HS requiring full dose ticagrelor, any contraindication and cardiogenic shock, and the need for chronic oral anticoagulation. Primary endpoint was a net composite outcome, death, semi-stroke, stent thrombosis, clinical urgent revascularization, and clinical relevant bleeding. This is the same in the Twilight trial also, and we evaluated the secondary outcome. Tailored CHIP trial almost enrolled more than 82.3% monthly, 56 patients actively enrolled. We are expected at the end of this year, we completed 2,000 patient follow-up completion, and then 1.5 years later, and ESCC, ACC as a late-breaking trial, we will present a primary result. And the key message of a tailored CHIP trial, optimal antithrombotic strategy, cornerstone of management ACS or PCI, and consistently evolved in the recent year, balanced and ischemia and bleeding. East Asian population and the reduced anti-ischemic benefit, increased bleeding risk during antithrombotic strategy compared to Western. Or one size fit all approach is not suited to antithrombotic strategy for East Asian. Careful assessment of thrombotic risk versus bleeding is required via tailored potential dynamic strategy as well as treatment plan based on individual risk. Thank you for your attention.
Thank you very much, Dr. Park. Next trial is Assure DES trial by Dr. Ahn. 안정민 선생님 계신가요?
그 다음 선생님 아시죠, 선생님? 그러면 조성수 선생님.
All right, so we'll have Dr. Cho present EPIC-CAD, and hopefully Dr. Ahn will show up in the meantime.
Okay, thank you, Mr. Chairman. Good morning, ladies and gentlemen. It's my great honor to present my talk in here about the currently ongoing EPIC-CAD trial. Frankly, I am an electrophysiologist, but not the interventionist, and this is the collaboration of our EP team and our intervention team. So, again, I'm grateful to the Dr. Park and SJ Park and all intervention members for such a great collaboration and giving me a chance to present my talk in here. All right. As you know, that the AFib and carotid disease shares many clinical risk factors. And about 7% of all patients PCI have AFib, and 1/3 of the patient with the AFib has carotid disease. This is our data. About 10% of the patients with AFib have any degree of, significant degree of the carotid disease, and they were at the high risk of the stroke or systemic embolism. So for the AFib, the fundamental for the stroke prevention is the oral anticoagulation. The active W study demonstrated the OAC is better than the clopidogrel and aspirin. So the current guideline, antiplatelets are not recommended, class 3 in our ESC guideline. But for the coronary disease patient, we consider about the stent thrombosis and also consider that the bleeding became the critical safety issue in the recent era. So for the AFib, the anticoagulation is required, and for the PCI, the antiplatelet is required. However, 1 plus 2 cannot be the 3 because of the risk of bleeding. Sorry. The OCTIVUS trial is the first trial that deals with this issue, that the warfarin-based double therapy is better than the triple therapy in terms of safety as well as efficacy. And in the NOAC era, 4 major trials immediately after PCI trial up to 1 year demonstrated that there is a NOAC is better than the warfarin and the dual is better than the triple, especially in terms of the prevention of bleeding. However, there is still concerns about the stent thrombosis. But the current era guideline showed that recommended the shortest period of triple therapy and dual therapy up to 1 year, and after that the NOAC monotherapy. But there is many evidence for this before 1 year, but after 1 year there is the evidence was sparse. The OAC alone trial is the first trial that directly deal with this issue. They randomized 700 patients after 1 year after PCI, and they failed to demonstrate the non-inferiority of the warfarin alone compared to the warfarin plus SAP, maybe because of the number. But the trend of the primary clinical outcomes are very similar. And the FIRE trial, which published about 3 years ago, is the first trial and the largest trial on this issue. And they randomized about 2,000 patients into the rivaroxaban-only group versus rivaroxaban plus antiplatelet group. One thing please keep in mind is that this trial used the off-label underdosed rivaroxaban, the 50 milligram as a standard and the 10 milligram as a low dose. This is different from our guideline that the standard dose for the stroke prevention is 20 milligram. Anyway, they showed excellent non-inferiority as well as the even superiority of the monotherapy compared to the combination therapy, as well as in the decreased risk of bleeding. Especially the rivaroxaban monotherapy showed a high, significantly lower rate of hemorrhagic stroke or CV death or non-CV death. The FIRE trial is a very well-designed and well-conducted trial. However, there are some limitations. First of all is that the tested dose of rivaroxaban is off-label underdosing and insufficient data on the extent and the severity of coronary disease, and it was early terminated. So we are conducted the EPIC-CAD trial. The principal investigator is Ki-Byung-Nam. He's our boss, and the Dieter Park is the principal investigator. The background question is what is the optimal anticoagulation treatment for the patient with the stable coronary disease? And so we conducted a multi-center open-label randomized trial comparing the edoxaban alone versus edoxaban plus antiplatelets. We enrolled about 1,000 patients and randomized them into the 2 groups, edoxaban monotherapy and edoxaban plus a single antiplatelet therapy. We used the standard dose of edoxaban, 60 milligram as a standard, and 30 milligram for the dose met the dose reduction criteria. The primary endpoint is the net clinical outcome, the composite of the all-cause death, stroke, systemic embolism, MI, unplanned revascularization, major and relevant non-major bleeding. The inclusion criteria consists of the non-bevel IP with the high strong risk and the stable coronary disease, which is defined as imaging-confirmed coronary disease, and the revascularized CAD. And we enrolled the patient after 6 months after the PCI for the stable coronary disease, which is close to the recent TAP guidelines. And the exclusion criteria will be the intracranial hemorrhage and the valvular AFib. And I already said about the clinical outcome is the primary endpoint, and each component of the primary outcome will be the secondary outcome. We have some unique methodology features of the EPIC-CAD trial. We use the on-label dosing of epiloxaban, and the stable coronary issue after 6 months after PCI is more close to the contemporary guidelines. And we will collect more detailed data on the disease extent, functional studies, and revascularization status. We have already completed enrollment at the last year, and the protocol paper was published in the American Heart Journal, and we were waiting for the follow-up data, and maybe we will present the result in the next year. So in summary, patients with coronary disease and AFib are fundamentally high-risk patients. NOAC and single antiplatelet is recommended currently after the PCI for 1 year. And NOAC monotherapy is recommended in current practice guidelines, but there is evidence very sparse. So we expect the EPIC-CAD trial will yield definite and unique data concerning the edoxaban-based antithrombosis strategy in this complex and high-risk patient population. Thank you for your attention.
Okay, now we will hear from Dr. Ahn.
Thank you, Dr. Gary Mintz. My topic is the ASSURE-DS randomized trial, the preoperative antiplatelet therapy in patients with drug-eluting stent undergoing non-cardiac surgery. Actually, there could be some event in patients who underwent non-cardiac surgery. The cardiac event is associated with the preoperative, intraoperative, postoperative factors, particularly in patients who underwent the DES previously. So the cardiac risk could be increased. Previously, we is well known that the non-cardiac surgery is well known the risk of stent thrombosis in patients underwent first generation drug-eluting stent. So how many patients who with the DES need non-cardiac surgery? We don't know exactly, but the Japanese data show that 10% at 1 year, 20% at 3 years. So 1 out of 5 patients who underwent the DES at 3 years need non-cardiac surgery, so require some modification of antithrombotic therapy, antiplatelet therapy. So this is a guideline. 2016 guidelines show that in patients treated with the DAPT after coronary stenting, the discontinuous P2Y12 inhibitors recommended aspirin if possible. ESC guideline was more strict, independently of time frame between the DES implantation and surgery. Single antiplatelet therapy, preferably aspirin, should be continued. But you have to know that the evidence is expert opinion, no proper randomized trial. 2022 ESG guideline also said that in patients with the previous PCI, continuous aspirin is recommended if bleeding risk allows. But this data is just data from the subgroup analysis from the large randomized trial. So what is the evidence? This is subgroup analysis from the POS2 trial. They compared the placebo versus aspirin in patients who underwent PCI, bare metal stent, or some patients drug-eluting stent. Compared with the placebo, aspirin group reduced the risk of death plus myocardial infarction, but no change in the major bleeding. But look at the death plus myocardial infarction, death rate no difference, but mostly due to the myocardial infarction defined by the enzyme elevation. So this is the POS2 trial. They tested the aspirin versus placebo in the high cardiac risk non-cardiac surgery. This is the primary analysis. The no difference regarding death, non-fatal myocardial infarction. Major bleeding is significantly higher in patients in the aspirin group. So another study to see the aspirin effect before bypass surgery, the aspirin neither a low risk of death or thrombotic complication nor the higher risk of bleeding than placebo. So aspirin no effect on the patient outcomes after bypass surgery. So what is the clinical situation in Korea? The Severance Hospital's registry show that the 43 patient who stopped the aspirin before non-cardiac surgery in patient who underwent DES before. Those patients, the continued single aspirin is to show that the lowest of those, the less than 7 years discontinuation show that very nice the long-term outcomes. So look at the Paris registry. Paris registry evaluate the stopping antiplatelet therapy after the drug-eluting stent implantation. The interruption is the guided stopping of antiplatelet therapy by doctor. So interruption is not associated with the myocardial infarction, stent thrombosis, and cardiac death. Disruption means the stopping antiplatelet therapy by themselves associated with a higher risk of event. So what is the real status? Cessation of antiplatelet therapy, maintenance antithrombotic therapy before non-cardiac surgery. We evaluated the 5 observation study, 4,880 patients. Surprisingly, the 56% of patients stopped the aspirin before non-cardiac surgery. We summarized data, ischemic event, bleeding event. Stopping aspirin did not affect the ischemic event and bleeding event. So currently we don't have any firm evidence from the random trial, which is the better strategy, stopping aspirin or continuous aspirin before non-cardiac surgery in patient underwent the DES previously. How about the U.S. status? Even in the United States, 24% of patients stopped antiplatelet therapy more than 5 days before non-cardiac surgery, but the antiplatelet cessation was not associated with outcomes. So we designed the ASSURE-DS randomized trial. We will enroll the patient who underwent DES implantation more than 12 months before non-cardiac surgery, patient without acute coronary syndrome or recent myocardial infarction. We excluded elective surgery, intracranial, intraspinal, and retinal surgery. Other elective surgery was enrolled randomization into one arm, aspirin only during the surgery. The other arm stopped all antiplatelet therapy, followed up the 1 month. The composite endpoint is all-cause death, stent thrombosis, myocardial infarction, and stroke. We also enrolled the registry if a patient refused to get the consent or some high bleeding risk operation. This is objective of this trial. Compare the clinical efficacy and safety of antiplatelet therapy in patients undergoing non-cardiac surgery for more than 12 months after PCI with the DES. This trial compared outcomes of discontinued antiplatelet therapy groups and aspirin alone treatment group. Primary endpoint is a composite of death, stent thrombosis, and stroke 5 days before and 30 days after non-cardiac surgery. Inclusion criteria is like this. Exclusion criteria is a symptomatic coronary artery disease patient and patient who needed for another anticoagulation therapy. Sample size is estimated 900 patients based on the past 2 subgroup analysis. This is trial procedure and follow. Patients are randomized to aspirin alone or non-antiplatelet group. Aspirin alone group takes only aspirin for 5 days before surgery. Patient on single P2Y12 inhibitor changed to aspirin from 5 days before operation. Patient on DEPT changed to single aspirin from 5 days before operation. DEPT resumed post-operatively as soon as possible. No antiplatelet group discontinue all antiplatelet agent from 5 days before operation. Antiplatelet agent is resumed as soon as possible after operation, or patients are followed up by outpatient visit or telephone at 30 days after surgery. This is ASSURE-DS randomized trial. Currently enrolled 92% of patients. So ASSURE-DS trial is a prospective multicenter, the randomized trial to compare the safety and efficacy of aspirin cessation or not in preoperative period of non-cardiac surgery in patients who have undergone PCI with the DES for more than 12 months. It may help to determine optimal antiplatelet therapy in patients who underwent PCI with the DES before non-cardiac surgery. Thank you for your attention.
Next is the RENOVATE Trial. Dr. Kim Ho-jin.
Thanks to the Society for the opportunity to present. My name is Hoyun Kim. I'm a cardiac surgeon from Asan Medical Center. In contrast to TAVR, surgeons have two options during TAVR. One is mechanical and one is bioprosthesis. And despite that, mechanical valve has an advantage of long-term durability over bioprosthesis. Just mechanical valve is less and less used, and bioprosthesis is increasingly used in the recent era just because of just its advantage of just avoiding anticoagulations and just possible future valve-in-valve used. However, when we look at the Korean national data, over 15 years, over 15,000 patients, and which we just recently published in JAMA Cardiology, and we can see the survival benefit of mechanical valve over bioprosthesis has persisted up until in the subgroup of patients less than 65. And just we can see the same age cutoff value of less than about 65 years in the same cubic spline curve analysis. So we may say that mechanical valves is maybe just possibly just underutilized in the real world practice now. However, as we all agree on that, just living with coumarin is very uncomfortable and very painful, and just lower quality of life ensues and after mechanical aortic valve replacement. So we say that if we are able to use the DOAC just instead of coumarin after mechanical aortic valve replacement, and also if it shows just reproducible comparability and safety, and that just could be a game changer just in deciding mechanical versus a bioprosthetic valve during SAVR, also as well as SAVR versus TAVR. But we already know that after 10 years ago, just real-line trial was terminated prematurely because that just patients who received dabigatran showed a higher risk of bleeding or thromboembolism. So, but that trial, the lessons from real-line trial, we just speculated that DOAC just could be as safe and as effective as coumarin if it is used after 3 months after surgery, particularly in the aortic positions and for the patients who had normal systolic functions. So we designed a randomized trial who evaluated the long-term just safety and efficacy of factor Xa inhibitor versus coumarin after mechanical aortic valve replacement. So we randomly assigned those 1,300 patients to 1-to-1 after mechanical aortic valve replacement, at least 3 months after operations. And primary endpoint was cardiac death, valve thrombosis, and valve-related thromboembolism and major bleeding, and at 12 months. This is a non-inferiority trial design, and the anticipated percentage of primary endpoint of 15% with a non-inferiority margin of 5%, which gave us 13,000 patients and with a power of 80%, alpha level 0.05. This is the multi-center randomized open label data, and we randomized stratified by the presence of atrial fibrillation in participating sites. In the rivaroxaban group, patients was taking 20 milligrams of rivaroxaban daily and 15 milligrams for patients who had a renal impairment. And for the coumarin warfarin group, a dose was adjusted to meet the target INR between 2 and 3. Secondary endpoint was all-cause death and individual components of a primary endpoint, valve thrombosis, and all the other echocardiographic parameters. we just included the patients over aged 19 years and more, and who had at least 3 months after mechanical AVR, and also has optimal hemodynamics manifested by a mean aortic valve gradient less than 20 and Vmax less than 3. And we excluded those patients who had a very old generation mechanical valve, like a Bowl and socket, stuff like that. And also who also had already implanted a mechanical valve in the mitral or tricuspid valve position. Also has a severe mitral stenosis and is related to valvular AFib. Also had a history of a stroke or impaired renal function or impaired systolic function. Other than that, we also included a patient with an increased risk of bleeding or any history of PE or infective endocarditis. Also has decreased life expectancy less than 12 months. This is a multi-center study, and currently there are 12 participating centers in Korea. But recently, just we hear in the news that PROACT-10A trial was terminated last year because just a big subgroup had a sort of increased risk of stroke. And after that, we reviewed all our just clinical data so far, but we haven't seen any increase in the adverse event related to the use of rivaroxaban. So we reported to FDA, and we said that there are some difference in the medication and ethnicity and the type of mechanical valves. So we we're still continuing that trial, but if it shows in the future if there's any increase in the adverse event related to the use of rivaroxaban, this study also may prone to the discontinuation. So far we have enrolled about 220 patients, and we just enrolling the patients between 15 to 20 patients a month. So in the future, just maybe if rivaroxaban shows just comparable safety or efficacy like Coumadin, in the future we just anticipated that just aortic threshold using the mechanical valves in the aortic position may be increased, and that could be maybe a game changer, just deciding the mechanical versus bioprosthesis as well as SAVR versus TAVR. So we're looking forward to seeing the exciting future. Thank you so much.
Okay, so now we go to FATE main trial by Duk-Woo Park.
Okay, thank you. So I'm going to introduce the new, just before starting this trial, and the funding was confirmed. And the FATE main trial is FFR guided versus angio guided PCI inpatient unprotected left main disease. Why FFR for left main disease? And as shown, the first case in today live case demonstration, angiographically sometimes mismatch and it looks like a significant stenosis, but FFR is 0.80. We do medical therapy, and IVUS shows some negative remodeling. Some different case, it looks like insignificant stenosis by visual estimation. It looks like 30%. FFR was 0.70, and there was plaque rupture. Lumen area is 6.2. And like this, this is looks like insignificant stenosis by visual estimation. However, FFR value was 0.72, and the lumen area 4.0, and the diffuse disease. This is absolutely same case shown in the today first live case demonstration. Like this, and the intermediate left main disease and os-shaft mismatch presence nearly 40%. And this is some representative case of a visual and the FFR physiology, the mismatch cases. So in this review article, we suggest a practical approach evaluation left main disease, especially for intermediate left main disease. Look at the Excel trial inclusion criteria. They define the a visual estimation, angiographic diameter stenosis more than 70%, randomization PCI versus bypass surgery, and the intermediate 50 to 70%, one of the following, IVUS minimal luminal less than 6.0 or FFR less than 0.8. You know, and some intermediate main the region is the real assessment, physiology and anatomy concept is difficult. Also, Excel main QCA data, this is available in the published in JAG intervention, and the ostial and chapter region, distal left main bifurcation region, diameter stenosis, this is QCA finding more than 50% is 36, 37, and looking at the left main diameter stenosis percentage, 65%, 64%. That means half of patients, more than 70%, half of patients, less than 70% in the many proportion requiring something beyond the angiography alone. So, and this is a free combat data. It's shown the New England Journal of Medicine supplement 3, and more than 70 is half of a patient in PCI CABG group, and intermediate 50 to 70 is half of a patient shown in the even in Excel trial. So, and the IVUS or the physiologic evaluation could work in left main disease. Also, compared to the prior Hemingway's data, they recommended the 6.0 cutoff value. And if you're gonna do 6.0 cutoff value, half of a patient FFR more than 0.80, half of a patient less than 0.80. The reason why we provide a more stringent cutoff criteria. So, and like this, for even left main PCI, we have a very nice tool and physiology and the imaging. So even after left main crossing over and the sulc ostium and the stenosis looks like significant. If you're gonna do FFR, many proportion is more than FFR 0.8. If you do on the basis FFR value, leave it alone, long-term outcome is quite good. So, and the reason why we do FATE main trial, and we defined angiographic diameter stenosis more than 50%, and we're targeting 930 patients with a significant left main disease, and the randomization, one arm is angiographic guided left main PCI versus FFR guided left main PCI, and the primary endpoint is the same, nearly same to ischemia trial, death, MI, hospitalization for unstable angina, heart failure hospitalization, or resuscitated cardiac arrest, or repeat revascularization at 1 year inclusion, as mentioned, and the visual estimation defined more than 50% diameter stenosis with or without concomitant non-left main disease or amenable PCI with drug-eluting implantation, and the V exclusion severe tortuous calcified region that did not allow the FFR assessment, also too much complex region, and the STEMI and cardiogenic shock, and the primary endpoint already mentioned. We also measured several functional status and several key secondary endpoints. So key message is my last slide. In contemporary clinical practice, goal of the PCI is to achieve complete functional revascularization of ischemic territory. Thus, theoretical, practical concept of physiology guided PCI will also work even in left main PCI. For all borderline or intermediate left main disease, it is strongly recommended to confirm physiology region significance before treatment using FFR evaluation. Non-ischemia producing region should not be treated. In the FATE main trial, we assume improved outcome with FFR-guided PCI are likely the result of more judicious PCI is in the targeting ischemia-producing left main region. Also, non-ischemia-inducing left main region, we just do OMT alone according to the guideline, and the funding was confirmed by Abbott and Boston. We're gonna just start before this trial. Thank you for your attention.
And the last trial from Awesome Medical Center will be presented by Dr. Kim. DM multivessel disease state-of-the-art PCI CABG trial.
Yeah.
Define
Thank you for introduction. Hello everyone, I'm Hoyun Kim, a clinical fellow from Asan Medical Center. It's an honor to present here. I'm going to talk about Define DM trial, comparing state-of-the-art PCI versus CABG in diabetics and multivessel disease. I have nothing to disclose. Before we start, we have to note that diabetes is a common comorbidity among patients with coronary artery disease, and diabetic patients have a more aggressive form of atherosclerosis, more extensive coronary artery disease, and higher risk of ischemic cardiovascular events and mortality. Diabetes is a major determinant of adverse clinical events after myocardial revascularization. There are several previous trials comparing PCI and CABG in patients with diabetes and multivessel disease. Syntax trial randomized 1,800 patients with left main and/or three-vessel disease, and their diabetic subgroup analysis included 452 patients with diabetes, and the results showed that the composite of death, MI, stroke, or repeat revascularization occurred more frequently in the PCI group, and repeat revascularization, PCI group had higher risk of repeat revascularization. And the BEST trial randomized 880 patients with multivessel disease with a median follow-up duration of 4.6 years. The primary outcome showed that CABG was associated with lower rates of primary composite outcome. And their diabetic subgroup analysis showed that in patients with diabetes and multivessel disease, the primary composite endpoint of death, MI, or TVR occurred frequently in the PCI group. And last year, the BEST extended follow-up study was reported, and they showed that PCI and CABG, there was no difference. In primary composite of death, MI, or TVR, and all-cause mortality, there was no difference between the PCI and CABG group. And diabetic subgroup analysis showed that CABG was associated with better outcomes. However, composite of death, stroke, MI, and all-cause mortality, there was no difference between the PCI and CABG group. There are some limitations of prior trials. The Syntax trial and the BEST trial have not focused on the diabetic patients, so their analysis were just subgroup analysis with underpower. And the Syntax trial included patients with left main disease. So there are two trials which included patients with diabetes and multivessel disease. They are Freedom Trial and BARI-2D trial. Freedom Trial randomized 1,900 patients with diabetes and multivessel disease, and they showed that CABG was associated with lower risk of composite of death, MI, or stroke, and all-cause mortality also lower in the CABG group. And Freedom Follow-up study showed that all-cause mortality was in CABG group, all-cause mortality was lower in the CABG group. And BARI-2D trial randomized 2,300 patients with type 2 diabetes and coronary artery disease, and they showed that survival between revascularization and medical therapy, there was no difference. And in both PCI and CABG stratum, there were no differences between revascularization and medical treatment. And 5-year MACE-free rate was not different between revascularization and medical treatment. However, in CABG group, 5-year MACE-free rate was higher in the revascularization group compared with medical therapy group. So based on the previous trials and subgroup analysis, a 2021 coronary artery revascularization guidelines suggest that in patients with diabetes and multivessel disease with LAD involvement who are appropriate candidates for CABG, CABG is recommended in preference to PCI to reduce mortality and repeat revascularization with class 1 recommendation. And those who are poor candidates for surgery, PCI can be useful to reduce long-term ischemic outcomes with class 2A recommendation. However, they have limitations. Freedom and Syntax trial did not use current generation DES, and Syntax Freedom trial did not frequently use intracoronary imaging. And Freedom BARI-2D trial did not use optimal medical treatment of current practice. FAME3 trial last year was reported, and they randomized 1,500 patients with cerebral vessel disease to FFR-guided PCI using second-generation DES and CABG, and they showed that PCI was not non-inferior to CABG. However, and in diabetic subgroup analysis, in patients with diabetes, CABG was associated with better outcomes. However, intravascular imaging was only used in 12%. And earlier this year, RENOVATE Complex PCI Trial showed that imaging-guided PCI compared with angiography-guided PCI, imaging-guided PCI showed better outcomes. So which should be better, imaging and physiology-guided state-of-the-art PCI or CABG? Maybe we could not answer based on the previous trials. So we plan to conduct DEFINE-DM trial, diabetes-centered evaluation of revascularization strategy of functional and imaging combined state-of-the-art PCI or CABG in patients with diabetes and multivessel disease. The objective is to compare outcomes of imaging and physiology-guided state-of-the-art PCI with CABG in patients with diabetes and multivessel disease with LAD involvement. It will be a multi-center international randomized controlled non-inferiority trial, and approximately 1,200 patients will be enrolled from international health centers. This is a trial design. 1,200 patients who are equally eligible for PCI or CABG will be one-to-one fashion randomized to standard CABG or imaging and physiology-guided state-of-the-art PCI, and the primary endpoint will be the composite of death from any cause, MI, or stroke at 2 years. And consecutive patients with diabetes and multivessel disease defined as angiographic diameter stenosis over 50% who are equally eligible for PCI or CABG will included, and patients with unprotected left main disease requiring revascularization, complex coronary artery disease anatomy that PCI is not suitable, ST elevation MI patient, with patients presenting with cardiogenic shock or severe AV dysfunction, patients with life expectancy less than 2 years will be excluded. Primary endpoint will be a composite of death from any cause, MI, or stroke at 2 years, and secondary outcomes will be each individual component of primary outcome and death, MI, stent thrombosis, bleeding, and length of hospital stay, rehospitalization, and functional class. So in conclusion, the result of the previous trials suggest that CABG is better than PCI in patients with diabetes and multivessel disease. However, there are limitations for accepting those results in the contemporary PCI era. So DEFINE-DM trial would provide valuable evidence for comparing imaging and physiology-guided state-of-the-art PCI and CABG in patients with diabetes and multivessel disease. Thank you for your attention.
Okay, we have about 15 minutes for discussion, and I'm going to start off just with one general comment. There are several pharmacology studies, including changes in pharmacology at a 6-month period of time, yet the primary endpoint was only at 12 months. That seems inadequate to me, especially since we know that the bleeding complication, which is what you're trying to avoid, really, is cumulative. And, and I don't really think that 12 months in some of these studies is adequate. That's just my personal opinion.
So just truly impressive, truly impressive. So many trials, well thought out, not just coronary or valvular intervention, now expanding into EP, cardiac surgery. When are you going to include heart failure?
The surgical study is really kind of interesting because this is a question that's been kicking around for decades and decades. The fact that the mechanical valves really have tremendous durability, but you've got the whole management of anticoagulation, and you have the balance against you don't want thrombotic or embolic events complication. But that's been unanswered and unaddressed really for a long time. And the biologic valves particularly in younger patients. Well, maybe, TAVR is changing that, but the biologic valves have always had a problem in younger patients.
I expect some challenge in enrollment in the mechanical valve study. I have relatively large practice. I've been in this hospital for 36 years. In my practice, I have less than half dozen patients with mechanical valve. So I will be happy to see rapid enrollment, but I expect some issues. I don't know how many people practice medicine outside Asia. So especially pharmacologic trials, antithrombotic, the Koreans, at least when I was in Korea 40-some years ago, DVT was something very rare. So hemostatic system or thrombolytic system in endogenous are different. So for people practice medicine, Gary or Dr. Goldberg, can you just adopt, do you feel comfortable adopting this trial done exclusively in East Asian?
Please go ahead first.
Not really.
Yeah. Yeah, it's unique, it's a different patient population from what we see in the US.
So then, Dr. Park, do you have any plan to include centers from Australia and New Zealand?
Yes, I think that is one of important question. Many clinical trial, including Plato trial and Triton-TIMI trial, was published, and our experience after new drug approval, prasugrel, ticagrelor, at the time we are 100% adaptation, same dose, but we experienced a very fatal bleeding and serious bleeding. Also, in the many clinical trials done East Asian population, including MK Hong, Severance Hospital, Assam Medical Center, and Seoul National University, consistently shows the bleeding event much higher than Western population, ischemic event much lower, and we call the East Asian paradox. And the several mechanism was proposed in many Japanese doctors doing the stop depth some similar trial, but it's sometimes too much complex. Western different story, East Asian different story. In real practice, sometimes in some headache. So,
what I don't understand, for example, statin, right? In Korea, you give Atorva 80, right? That's allowed. In China, I believe the highest approved dose is 60 Atorva. In Japan, 20. So what I understand is the genetics of Koreans, Chinese, and Japanese, they are pretty much the same. Where does it come from? The maximum allowed dose of 80, 60, and 20.
Well, the regulators.
No, there was a paper, is Dr. Akasaka here? There was a paper with 20 milligrams of Atorva in the Japanese population. You get comparable LDL reduction.
But by the way, not too long ago, 20 was the maximum, I believe, that was allowed in Korea. Was that right?
Yes. What I mean is our studies, mainly is not drug dose. What I mean is mainly focusing the strategy itself. What I mean is in the typical example of the ASSURE-TES, the stopping the aspirin or not is a common need when we have a practice. That is a typical example. And the EPIC-CAD is also a similar one. It's we mainly focus in such kind of some strategy. We need a clinical answer. When I hearing the presentation, I really happy and enjoy the whole presentation. And one of the best one is enrollment was almost to be finished. So or maybe soon they answer about it. And the second one is the statin dose. Frankly speaking, 10 years ago, 20 years ago, personally, we prescribed a very low dose of the statin. 50% of the reduction, okay, commonly seen. But nowadays, when we prescribe the more higher dose, the percentage of the achievement is not low, not high.
Yeah.
Is that some economic situation is changed?
Yeah, it's not linear. The decrease in LDL is not linearly related to the dose of atorvastatin, a doubling, I can't remember exactly what this is, a doubling of the dose is associated with a 10-point reduction in LDL on average.
And I'd like to emphasize that the statin study was as I said, there is only one guideline, one strategy, high intensity statin, whatever what it is, anyhow, that is only one guideline. But clinically, maybe we need some alternative. I'd like to recommend some alternative, but there is no evidence.
Yeah.
Previous whole study was the random to high intensity or low intensity, whatever it is. So therefore, the writer or the member of the guideline development, they should maybe recommend only that, because if they recommend the others, maybe argue about is there any evidence? No.
Yeah.
The way we respond is guideline. And we
Practice is
incorporate the recent data in addition to guideline. Like cholesterol management, Korea data, Korea trial provides so much data. We don't use just high intensity study and forget it. We see the response and see recent data. We incorporate and try to provide best possible care.
The other thing that struck me is the atrial fibrillation study, because in the U.S., so many of these patients are getting LAA occlusion. And, it's also the same issue. My question is, what's the popularity of LA occlusion in Korea, and how is that going to affect your study?
Thank you for the great question. In Korea, the area appendage occluder is very underutilized because of the insurance issue. In the Korea, we only implant the patient with those who refractory to the NOACs or has a major bleeding after NOACs. So refractory or intolerant patients only receive the appendage occluder with 80% of the charge by themselves.
How about ablation?
Ablation, about only 5 to 10% was charged. About 90% is covered by the insurance. So the ablation is very widely used, but the appendage occluder is very underutilized. So I don't think the area appendage occluder affect the current study.
Dr. Park, the trial for aspirin during perioperative procedure, and I understand the enrollment is after 12 months of PCI?
At least 6 and 12 months PCI, and then the before the surgery, the one arm is stopped and the one arm is non-stop.
But clinically more headache is patients who just had a stent and now has to undergo urgent or unexpected surgery, and what to do with those. And we routinely give Pangreilor.
Yes, target population is already stabilized the
Yeah.
patients beyond the 6 and 12 months.
But it still is a valid question.
Oh, yes.
And I think it also depends on the surgeon as well. In Singapore, we are typically being careful, afraid to lose that. Even dental surgery procedures, we were asked to stop
Aspirin?
both DAPT. Yeah. So I think it's you have to convince the surgeon as well that to stop to continue the aspirin is safe for the patients. Yeah.
Yeah, other than neurosurgeon, they are mostly receptive.
Yeah, some of the cancer surgeons is also problematic.
Yeah, aggressive.
Okay.
One question to ask Dr. Min is, at the moment, imaging is still as 2A recommendation. What sort of trial and what sort of results of that you think that you will make this imaging into a class 1 indication?
Okay, so you should ask the people on the guidelines, not me. Because the guideline committees are clearly prejudiced against imaging. There are more data on imaging than on physiology, yet physiology is class 1. There is emerging negative data on physiology, yet physiology continues to be class 1. There's more data emerging on imaging, yet imaging is still class 2. I'm told that they almost made it class 1. whatever that means. I also think that there are people on the guidelines committees who are interventional cardiologists who don't understand how to use imaging, and if they were to recommend class 1 and they would go home and do cases without imaging, it would not look very good. I think that especially with RENOVATE, the next time the guidelines are issued, to not see class 1 would be shocking. But unfortunately, the guidelines don't get updated every year.
Any questions from the panel? Yes, Akiko.
Yeah, so this is not question, this is a comment. I really congratulate and to see, very look for the PREVENT trial because this is a really vulnerable plaque study. But my expectation is really probably that's positive, meaning treating the vulnerable plaque is safe and probably decreasing the event. That's my expectation based on the prospect of SOAP. However, the main question clinically is can we reduce ACS and especially MI event by putting the stent? So I hope you expand the study beyond 2 years and then to see what's happening in the future.
I mean, I think this long-term follow-up applies to many of these studies.
Yes.
Yeah, should,
Is there any study to win, interventional study, win the medical treatment? Usually touch of it?
PREVENT trial is an overall trial time 9 years ago. At the time, my hair color is black.
yeah, long time ago. Yeah.
So, almost done at least a 2-year follow-up. And then this year, 1,600 patients, we completed nearly 100% follow-up. At least we expect median follow-up more than 4 and 5 will be presented next year, ACC EPIC trial.
Sounds good.
So one quick question related to PREVENT or any vulnerable plaque. So what you are trying to prevent is not revascularization, right? Sudden cardiac death and MI. I understand it's hard to have enough events.
That's right.
Yeah. There is,
But-
I think the professor, Ik Jang mentions there is, I think, a major, obstacle of the PREVENT trial. Even though we enrolled 1,600 patient event, given GDMT is quite low. Yeah, there is a, we don't know yet. Yeah.
I mean, Prospect 2, LRP, the death MI rate is less as 1%,
Yeah.
give or take, per year.
Yeah. And if you look at all those trials and plus, the incidence of MI from TICFA, whatever, 4 years, 1%.
Yeah.
And the prevalence of TICFA in CAD patient is 30%. So if you truly believe that stenting of what you think is vulnerable will prevent MI, then 299 patients will have unnecessary stent.
Well, and that's just a one-time point. Bring them back in 6 months or a year. Okay. Thank you very much to the presenters. Truly an amazing parade of trials.